So welcome everyone who's joining me virtually today. This is a presentation on chronic fibrosing interstitial lung disease with a progressive phenotype. And today I'm going to be talking about diagnosis and patient management in this disease state. My name is Erin Peterson, and I'm a nurse practitioner at Minnesota Lung Center in Minneapolis. And I'm really passionate about the care of these patients with this challenging disease. And it's truly a disease state where knowledge can make a huge difference in the life of the patient. So I'm so thankful that you are joining me today and hopefully learn a lot and can take home some things to your own practice. And first, just a disclosure, this presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines. And interstitial lung diseases are a diverse group of conditions that may result in lung fibrosis. There are over 200 different interstitial lung diseases within this term or within this umbrella diagnosis of ILD. So really a lot to know about ILD, but all of them do share some things in common. ILDs are associated with an underlying mechanism of there's damage to the lungs, varying degrees of inflammation, and therefore fibrosis. And some ILDs can have a progressive fibrosing phenotype in which an underlying mechanism of self-sustaining pulmonary fibrosis can develop. Within ILD, it helps to break it down into different categories and try to group things together that may behave similarly. And so underneath this umbrella of ILD, we see 5 broad categories. So starting on the left, idiopathic ILDs, those are ILDs without a known cause. Those may not have an identifiable cause. Hypersensitivity pneumonitis, those are ILDs related to a causative antigen, resulting in a hypersensitivity reaction in the patient. And there are many different substances that can be implicated in that process. And I'll talk a little bit more about those in the coming slides. Autoimmune ILD is really a huge group of ILDs, including conditions such as rheumatoid arthritis, systemic sclerosis, polymyositis and dermatomyositis, Sjogren's syndrome. So really some complex diseases within there that can be associated with interstitial lung disease. Next, we have a standalone category of sarcoidosis. Sarcoidosis is a rare disease characterized by the formation of granulomatous lesions. And finally, to the right is a category called other ILDs, which is really just a catch-all of some that don't fit in the other categories. These include some of the more rare ILDs, and also those associated with drug exposures, toxic drug exposures, or occupational interstitial lung diseases. Here on this slide, we see the pathogenesis of fibrosis. So there are 2 pathways that can happen. Starting on the left, we have an insult to the lung, and then a normal lung would follow a path of normal wound healing and allow the lung to return to normal functioning lung tissue. However, in interstitial lung disease and then that developing into fibrosis, a pattern of abnormal wound healing can happen. There can be a breakdown in the regulatory mechanisms that kind of set off an excessive inflammatory cascade, uncontrolled activation of cells called fibroblasts that start laying down this extracellular matrix in the interstitial space. And you'll see that represented here in the illustrated graphic. The normal interstitium. So the space in between the inside of the alveoli and the inside of the blood vessel. Normally, oxygen is diffusing easily across this membrane, as well as carbon dioxide. But with that abnormal wound healing, the deposition of this extra fibrotic material, that layer becomes thickened, scarred, and the lungs lose their function, their ability to diffuse that oxygen across that membrane easily. And so that's really what's happening down on the level within the lungs. And when we're looking for the possibility of a patient with a chronic fibrosing ILD, several things to consider. So first, can't stress enough the importance of really obtaining an accurate history from the patient. What are their symptoms? What kind of things could potentially indicate that this patient has a progressive fibrosing ILD? Most often things like exertional dyspnea, non-productive cough, making sure to ask about a family history. There are interstitial lung diseases that do have a familial component to them. Then moving on to physical and lab examination with abnormal chest imaging, crackles on exam, exertional desaturation is one of the first signs we'll see of patients, and pulmonary function testing. And I'll talk about each more of those a little bit more in the coming slides. But when you're seeing something from their history, something from physical or lab exam that might point to something, something's really going on here, that's a red flag to think, well, maybe this could be a chronic fibrosing lung disease and we need to look into it more. And I know in pulmonary rehab, not everyone who works in this field is a respiratory therapist and may not have training in interpretation of pulmonary function tests. But what I'm going to do is just break this down a little bit for you and just give you a mini lesson on what we might see in the pulmonary function tests of a patient with interstitial lung disease and fibrosis. So really what we're looking at is in the middle. So the restrictive defect pattern on pulmonary function tests is what we're expecting to see most often in a patient with interstitial lung disease with fibrosis. So in a restrictive defect, you'll see kind of a smaller peaked flow volume loop. And what we're looking for with the values on that testing is a total lung capacity that's reduced, so restriction in that total lung capacity. And then the forced vital capacity, the FEV1 FVC ratio is typically normal, so greater than 70%. Indicating an absence of airways obstruction. So this is typically the pattern that we see. Compare that to an obstructive defect, which you see on the left there. It has that ski slope appearance to the flow volume loop. We see an FEV1 FVC ratio of less than 70%. Total lung capacity may be normal or even supranormal. And that pattern is an obstructive pattern that really fits with obstructive lung disease, airway diseases such as asthma, COPD. So not expecting, would not indicate what we would typically see with fibrosing ILD. Not to be forgotten, however, is the fact that patients can have actually more than one disease process. Oftentimes, patients who have interstitial lung disease are smokers or former smokers. They may have concurrent COPD and interstitial lung disease and could potentially see both patterns, obstructive and restrictive, mixed together. So just adding to some of the diagnostic challenges of this disease state. And I cannot also stress to you the importance enough that high resolution CT scan is really essential for the diagnosis of these patients. They are far superior in detecting the tissue scarring compared to an X-ray. Some of you may or may not look at the images in your day-to-day practice. I encourage you, that's the best way to learn, is pull up the images, read the interpretation from the radiologist, and see if you can figure out what they're talking about and slowly learn what exactly we're seeing. Certainly, if you see some of these things mentioned on a report from a radiologist, it might raise some red flags to you, especially if the patient does not yet have a diagnosis of interstitial lung disease. But for example, just so I can show you the difference, the x-ray on the left is a chest x-ray of a 43-year-old female, 3 weeks of sinus congestion and clear sputum production after running. Her x-ray showed some subtle lower lobe scarring or fibrosis, and it's pretty subtle. It's right down here at the bases, could even be missed pretty easily. But if we put this patient through a high-resolution CT scan, what we can clearly see the formation of those lower lung abnormalities with honeycombing cysts and other features of pulmonary fibrosis. So to show you a bit more about those HRCT or high resolution CT features of fibrosis, I'm going to show you the 3 main patterns of changes that we see on those CTs. So on the left, one of the first things we will see in these patients is the development of reticulation. And reticulation is the result of thickening of these interlobular or interlobar septa. It can appear as several linear opacities, almost resembling a mesh or a net on a CT scan. And that finding is indicative of interstitial lung disease. Next on the far right picture of traction bronchiectasis. This is irreversible dilation of the bronchi. And by definition, traction bronchiectasis results from that fibrotic lung tissue contracting and pulling those airways open. There is standalone bronchiectasis in different diseases and its own disease, but when we see traction bronchiectasis, it's in this setting of interstitial lung disease. And then in the middle, we'll see our prototypical finding in many of the pulmonary fibrotic diseases, which is honeycombing. And you can see why it's called honeycombing. It really does look like honeycombs on an image. Honeycombing results from the deposition of dense collagen fibers. They destroy the alveolar structure and end up with these cysts of varying sizes with thick walls, and they start to layer up upon or stack upon each other. And so when we see honeycombing, we really are concerned about pulmonary fibrosis. That's what we're seeing. And it is important when we see a patient who has an interstitial lung disease to be able to identify the progression of that disease. And as pulmonary rehabilitation providers, you may be some of the first ones to hear about these things from the patient before anyone else, before their doctor's aware, before their some of their caregivers are even aware. You may see it or be aware of it first. And so things that we'll see when patients are having disease progression, we'll see worsening of their symptoms, their cough and their dyspnea, a decrease in their exercise capacity. If we were to do a CT scan, we might see increasing fibrosis. Their lung function is declining on pulmonary function testing. They can have acute exacerbations of their disease. And then also just a general sense from the patient or their provider, their physician or their nurse practitioner or PA that their disease has worsened. And so just a sense that this is getting worse, this isn't going the right direction. And so important to recognize those and make sure that it's being addressed and the team is aware of it. Here, you'll see some examples of the disease, the disease progression pattern that interstitial lung disease and pulmonary fibrosis can take. This is often something that I think is really helpful for patients to see. Many times I'll even draw this out for them in the exam room when we're talking about their disease and I'm giving them education about it. It's really an unpredictable disease course. This disease course is for idiopathic pulmonary fibrosis, which I'm going to talk more about. Some patients have a course that's slowly declining lung function. Survival can last several years. That's seen in this kind of top peach line. Some patients, unfortunately, can have a more rapid onset of symptoms and a much faster decline in lung function. And really at the beginning of that graph, they all start at the same spot. So it's hard to know which way things are going to go for that patient. Some patients may be somewhere in between. And then at any point, you'll see in the gray line marked by the dots, they can have an exacerbation or a flare-up of their disease, leading to a rapid onset of worsening symptoms. And then unfortunately, a significant drop in lung function can happen after that. There's a potential that they could level off. Their disease progression could slow down again. And again, having another risk for an acute exacerbation, quickly dropping their lung function. So just trying to recognize what pattern the patient might be on. A little bit more here about acute exacerbations in patients with IPF. So for example, if we were to look at the high resolution CT scan, the scan on these are from the same patient 5 months apart. So scan on the left is a baseline. We can see some of those findings we talked about, the peripheral reticulations, and the sense that something is going on more towards the periphery of the lungs and the bases. 5 months later, here's the same scan from the patient with an acute exacerbation of their idiopathic pulmonary fibrosis. They have new bilateral ground glass opacities, that's those hazy white opacities we see within the lungs on the imaging, and new areas of consolidation. Oftentimes these patients may even end up hospitalized with increased symptoms, increased need for oxygen, and unfortunately morbidity and mortality are high for acute exacerbations. Next part of the presentation today, I'm going to be breaking down for you a bit some more of the examples, a little bit more into each of the chronic fibrosing ILDs that are known to have potential for a progressive phenotype. And so here are 4 main categories of ILD groups that are identified as being potentially progressive. So idiopathic pulmonary fibrosis, we do know progresses, that definitely will progress. Hypersensitivity pneumonitis, or HP, autoimmune interstitial lung diseases are potentially progressive, and then unclassifiable ILD. And these are not all inclusive of all fibrosing ILDs that can have a potential to progress, but just some of the main ones. Other than IPF, only a percentage of patients in the other categories will go on to experience progression. IPF, or idiopathic pulmonary fibrosis, is the most common idiopathic interstitial pneumonia. So no known cause in that category under the ILD umbrella. It's a form of chronic progressive fibrosing interstitial pneumonia. We just unfortunately don't know at this point in medicine what causes it to happen and what causes that process to just continue in some patients. Unfortunately, the 5-year survival in IPF, about in 2012 when this study was published, the 5-year survival was between 20 and 40% in the United States. So not as known of a condition as some of our more common cancers like breast cancer, colorectal cancer, but unfortunately more deadly. Lung cancer tends to be a bit the worst survival on this screen, not something you necessarily want to be in a competition for the worst 5-year survival rate. IPF is rare in younger populations, so be thinking about that if you're seeing a patient who may have a progressive fibrosing lung disease. Typically rare in younger populations. Our prototypical patient with IPF is a male, former or current smoker, typically over the age of 60 years old. It's usually a 6th, 7th, 8th decades of life that we see patients presenting with idiopathic pulmonary fibrosis. And high resolution CT scan is absolutely essential for the diagnosis of IPF. So how we make that diagnosis, there's several criteria that need to be met. First of all, excluding other known causes of ILD. So that's where we go back to taking a really thorough history of the patient. You know, what did you do for a living? Was this someone who worked in a power plant and they were ripping out asbestos? Is this someone who has multiple family members who have sarcoidosis? You know, what other disease processes do they have? Do they have a known autoimmune disease? Does this person have rheumatoid arthritis or something else going on? So excluding all those other known causes, not only with a history, but we're taking usually a significant amount of serologic or blood samples in these patients for analysis. And then the presence of a UIP pattern, that pattern that I've shown you with honeycombing, reticulation, traction bronchiectasis, so the presence of that pattern, plus excluding other known causes, we can likely make a confident diagnosis of IPF. If it's somewhere in the middle, we may need different combinations of things. So sometimes patients will need to go on for actually a surgical lung biopsy. If the HRCT pattern has a probable UIP or possible UIP pattern, that patient may need to go on for further testing and actually undergo a surgical lung biopsy. And then looking at the different combinations and patterns on those. As I mentioned, IPF unfortunately does progress over time. Here is a cut from a same CT on a patient at the time of diagnosis, so year 0, where we see circled in those peach circles some reticulation. So early reticulation down at the lung bases and then along the periphery of the lung. 3 years later, same patient, same view of the lungs, and we see definite progression. You don't need to be a radiologist to see that things have gotten worse there. We'll see more of reticulation, and actually circled down in the bottom in the black circle, you'll see that early honeycombing where those cysts are actually starting to be more apparent and defined and stacked up on each other, indicating that's kind of that area is getting to an end stage of fibrosis. Here's a summative case example of a patient where we are making a diagnosis of IPF and what we would see. So first of all, the history. This is a 67-year-old person, an ex-smoker with a history of 20 pack years. They're not no known trigger drug use, no known inhaled antigens or agents. History of acid reflux or GERD. We send off all of the serologies. Those are all negative. On exam, mid to late inspiratory crackles, particularly in the lung bases. Paying attention to a patient with interstitial lung disease, taking a look at their fingers. This patient had digital clubbing present on exam. The pulmonary function tests, the values are listed out there, but they indicate a restrictive pattern on the PFTs. Then looking at that HRCT scan, we definitely see the UIP pattern. Each of those 3 distinct parts of that, the reticulation, the honeycombing, the traction bronchiectasis, those are all right there. And so this is a very typical patient that we would see who has a diagnosis of IPF. Moving on from IPF, I'm going to talk now a little bit about hypersensitivity pneumonitis, or HP. HP is an inflammatory and or fibrotic disease. They can have a spectrum in between there that typically results from an immune-mediated reaction provoked by an inhaled antigen. It's not incredibly common, 1.7 to 2.7 cases a year or per 100,000 people. Identifying the inciting antigen really can impact survival, because if we are able to identify the inciting antigen that's causing this ongoing hypersensitivity reaction, we need to remove that from the patient, or remove the patient from from that environment. Really interesting number of exposures that can lead to this. We see quite a few specific occupations and hobbies actually that patients can have a risk of developing HP. Farmers are at a big risk. So if you've heard of farmer's lung before, it's actually hypersensitivity pneumonitis. Gardeners exposed down in the dirt, lots of molds and spores. And then some kind of unusual occupations like cheese workers, working in plants where there's molds, malt workers working along all that grain dust that has the potential to also have molds and other antigens in it. Patients who are we call it bird fanciers. There are actually quite a few patients in the United States, or people in the United States who have hobbies working with breeding pigeons and things. So actually met a patient who competitively raced homing pigeons and unfortunately had developed hypersensitivity pneumonitis. So difficult conversation about removing the birds from his life. But that's kind of the things that need to happen in HP. No individual feature of any of the diagnostic testing we do is sufficient for a definitive diagnosis of HP. We really are looking at the whole, all of the pieces of the puzzle. So what are the features on their high resolution CT? Are we able to detect serum antibodies against known antigens? If they have a lung biopsy, does it fit with the histopathology that we would see for HP? Some patients will undergo bronchoscopy with BAL or a washing to analyze the cells. Does that contribute to the diagnosis? So really taking all of those into account can be a tough diagnosis to make, where not just one thing can really nail it for you. Here's an example. I'm going to show you a couple examples of the different patterns that HP can take on. So this pattern is a bit different, you'll notice, than the UIP pattern that we saw. We see much more ground glass opacification. So throughout that lung, just kind of that hazy, cloudy area on the images refers to what we call a ground glass opacity. Another distinguishing feature is something called mosaic attenuation. You'll see that in slide B, or in the image B. There's some arrows pointing to some areas of what we call air trapping, ground glass, but you'll see there's some distinct areas. And so that mosaic attenuation, the name is derived from mosaic artwork, where there's various colored stones or tiles kind of placed next to each other in contrasting patterns. And you'll see kind of well-defined bordered regions of different lung attenuation. So a really black area next to a really whiter area with ground glass. And so that contrasting pattern, if you read that on an imaging report or look at those images, is called a mosaic attenuation and can be seen in a non-fibrotic HP. Here's an example of a patient with hypersensitivity pneumonitis that has gone on to a fibrotic pattern. We start seeing some of those same changes that we saw in UIP: honeycombing cysts, reticulations, traction bronchiectasis, and then we may see also some of those mosaic pattern or air trapping ground glass opacity is superimposed. So the two of them really can see a lot going on those CT scans. Next, moving on to a big category of ILD, like I said, is the autoimmune diseases. So within that, lots of different distinct diseases and disorders: rheumatoid arthritis, systemic sclerosis, mixed connective tissue disease. So there's circulating onto autoantibodies in the patient that have a potential to target the lungs as one of the organs that will become damaged by these autoantibodies. Interstitial lung disease is common target organ for many of these disease processes. You'll see some of the common ones here in the pie charts. The percentage on average are an estimate of patients with that disease that can go on to develop interstitial lung disease as part of their autoimmune disease process. So you'll see some more than others. For example, a patient with systemic sclerosis, about 65% of those patients will have ILD. Even higher for something like antisynthetase syndrome, less for something like lupus or rheumatoid arthritis. But just to be aware when we're seeing those patients that have those diseases, that is a potential. Serologic tests can point to possible autoimmune disorders. So particularly in the diagnosis and workup of a patient who has identified interstitial lung disease. Again, this is why we send off a lot of different labs on these patients, and sometimes multiple waves of labs depending on what we get back. We're really looking to identify, can we pinpoint what is that cause? Can we figure out what is the autoimmune process that's happening? So for example, you'll see here some of the autoimmune tests, that the autoimmune serologies, and then what symptoms might go along with some of those tests. So for example, an ANA, a rheumatoid factor, that might be someone who has arthritis, rashes, morning stiffness. Some of the Sjogren's antibodies, the SSA and SSB, that might be someone who has dry mouth, dry eyes. Common Raynaud's phenomenon is seen where they have poor circulation in the fingers turn white, sometimes purple, can get digital ulceration. So really a lot to be looking for in these patients. Diagnosing autoimmune related interstitial lung disease, it's important to identify it early in these patients. So, taking into account their crackles on their exam, they might have positive serologies. What does their CT scan of their chest look like? What pattern is it? Do they have non-pulmonary manifestations? And then if we do get that HRCT that shows interstitial lung disease, going on for further testing, let's quantify what the lung impairment is like. What is their 6-minute walk test at baseline? What is their dyspnea? If not, it's important to still monitor these patients regularly, because as you saw in the last slide, a percentage of patients can go on to develop interstitial lung disease further in their disease process. So there's a risk of that. So monitoring them regularly, checking in on dyspnea, getting pulmonary function tests, really close auscultation of the lung bases, particularly for the development of fibrosis. The autoimmune lung diseases may not all have the same pattern. Actually, many of them have a pattern different from what we've seen so far, that UIP pattern. Some of them do have that UIP pattern. Some of them can have something different called an NSIP patterns, or non-specific interstitial pneumonia pattern. And particularly what you'll see different on this one, more rather than the reticulation and the honeycombing, this one you'll see more peripheral ground glass opacities. You also do see some of that traction bronchiectasis, and again, there can be overlap between these two patterns. So here's a summative case example similar to what I gave you for IPF. Here's one for autoimmune disease. And this is a patient with systemic sclerosis related ILD, also called scleroderma. The patient may come in complaining of shortness of breath or coughing, also accompanied by Raynaud's phenomenon, so whitening or poor circulation in the fingers. They have positive serologies. The high resolution CT scan shows honeycombing, ground glass, reticulation, and then a restrictive pattern on their pulmonary function tests. And finally, moving on to this category, the unclassifiable ILD, which calling something unclassifiable then turns out to be their diagnosis of unclassifiable ILD. So it really is, despite the review of the clinical findings, radiologic, review of their pathology from their lung biopsies, sitting down and having a multidisciplinary discussion, or MDD. There's no conclusion about what this disease is. And so there might be overlap, there might be some things you would expect to be present that aren't. And so we can end up with this unclassifiable. And those tend to have a risk to be progressively fibrosing. Unfortunately, the unclassifiable ILDs do carry a worse prognosis. 2-year survival is about somewhere range 70–75%. 5-year survival drops a bit lower. And then here's just a pattern of how you can follow through and get to that either confident diagnosis, a provisional diagnosis, or really just unclassifiable if we can't come to a conclusion. So for the next part of the presentation, I'm going to talk to you a bit about patient management. So we've talked about diagnosis, what we might expect to see in these patients and the different types of ILD. But let's move on to talking about management. Misdiagnosis of ILDs is unfortunately, extremely common, and I think it's very important to be aware of, as it can significantly affect the quality of life of these patients. And I think it's important, especially as pulmonary rehab and cardiac rehab providers, that you know that this may be what your patient has gone through before they get to their diagnosis and come to you to start pulmonary rehab. In one study of patients with ILDs, there are 600 patients who were surveyed. 55% had at least one misdiagnosis. 38% had 2 or more misdiagnoses. 3/4 of the patients need to go to 3 or more physicians or providers before they get to their diagnosis. And then over 1/3 of patients can have a delay of 2 or more years. So not only can that lead to further decline, that pattern or the disease is progressing over time and hasn't been recognized, it's just getting worse. No one knows what's going on. So worsening symptoms and then really impacting their quality of life. Really a stressful time for patients to be trying to feel like they're not getting answers. So recognizing ILD and accurately categorizing it is really critical to proper patient management, because if we don't have an accurate diagnosis, we don't know what the best path for this patient is for management. So we know as fibrosis progresses, patients become more breathless, less mobile, and less independent. So the earlier that we can identify it, the better, and then can move on to managing them. As I mentioned a minute ago, multidisciplinary discussions, we call them MDDs, are recommended for diagnosing ILD. ILD centers, so particular centers around the country with specialization in interstitial lung disease, are most likely the places where they'll have the proper resources to conduct a multidisciplinary discussion, or MDD. The team usually consists of a pulmonologist, radiologist, a pathologist, a rheumatologist. Primary care providers may or may not be involved. Advanced practice providers, such as a nurse practitioner like myself or a physician assistant, respiratory therapists, and on this list should be included pulmonary rehabilitation providers. If there's anything you might take away from this today, if you are at a center where there are multidisciplinary discussions taking place, I think it's very important for a pulmonary rehab provider to have a seat at that table and see, you will learn what this patient has gone through, might learn more about their disease and the particulars of that case. And maybe this would even be an option for a pulmonary rehab provider to interject and say, I think this sounds like a patient that would really benefit from pulmonary rehab. Can we get an order for that? So that might be something that, to think about if you're not already involved. Not only is it, helpful for the patients, it's really fascinating and a great way to learn more about these diseases. Patients with interstitial lung disease really have high needs for support. They have consistently identified the need for emotional support to deal with the anxiety of living with a chronic, progressive, life-limiting condition. Symptom mitigation, they need someone to hear about their symptoms and help them with a plan on how to manage them. They really will benefit from high quality disease-related education. The more that they understand, the knowledge is power for them, and they can take that and help direct their care and make sure that they're receiving what they need. And delays in diagnosis and then implementing this supportive care really can negatively impact the quality of life of both patients and caregivers. Non-pharmacologic management is a really important piece in the management of patients with ILD. Comprehensive care strategy, multiple things in there. Of course, smoking cessation. If a patient who has ILD is still smoking at the time of diagnosis, really that patient needs to get some help immediately to help them abstain from smoking and remain abstinent from smoking. We know that's often easier said than done, but every effort should be made to get that patient off of the cigarettes. Education, again, timely education. They're going to have so many questions about this. If it takes a continuing education presentation for healthcare providers to understand this disease, you can imagine a patient who has absolutely no healthcare knowledge about how the lungs work or what is happening in there, and then throwing this complicated condition on them, really need tailored and often repeated education. Psychological support in the form of peer support groups. There's online support groups, and really pulmonary rehab may be an ideal setting in which to provide education and the psychosocial support that these patients need. They may meet other people dealing with a similar disease or the same disease as them, and having the opportunity to tailor the specific information that that patient needs. So just a bit more about the comprehensive support and care for the patients, the management of ILD. In that center peach box, you'll see, kind of four main things. So providing oxygen, pulmonary rehab, symptom mitigation, and treatment. And we know that patients with ILD, hypoxia is extremely common. It's a huge leap for many patients to be willing to accept ambulatory oxygen, not just a concentrator, at nighttime, or in their home, but making that leap to accepting that oxygen may improve their physical functioning and therefore their quality of life, and also potentially improve their survival. But certainly a lot of educational needs come along with that, and many times many frustrations dealing with the companies, etc., the oxygen providers. As you all know very well, pulmonary rehab is absolutely fundamental for patients with lung fibrosis and should be included early in tailored exercise programs. Patients with ILD are very likely to gain meaningful benefits from pulmonary rehab in terms of their exercise performance, 6-minute walk, dyspnea, quality of life. All of those we know have a great potential to improve in these patients. Symptom mitigation should be addressed, so trying to help the patients the best we can to manage their shortness of breath, their fatigue. Cough can often be a very distressing symptom for these patients, so helping to at least be aware that we hear you, we know that you're struggling with this, and we're going to try everything that we might possibly be able to. Encouraging these patients to speak up about anxiety and depression and don't suffer alone, and letting them know how common it is in a disease like this. Comorbidities, so comorbid conditions, heart failure, obstructive sleep apnea, pulmonary hypertension, reflux, depression, all extremely common, can impact the quality of life and impact the survival of these patients as well. So making sure those are optimally treated. And then there's key management decisions that need to happen whether to administer pharmacologic agents or not, which is a whole nother education piece in itself, a lot for patients to understand there as well, whether they should be referred for a lung transplantation, or whether the disease is likely in its end stages and unable or unlikely to respond to therapies, and therefore perhaps supporting with a palliative may be the best approach. In my practice, I tend to discuss some of the end of life things, or at least touch on them very early. It's not that we need to, make any plans for anything now, especially if a patient is in their mild stages, but just to be aware, especially if they are an older adult, in their, 70s, 80s and beyond, that, this disease may progress. And it's important to start having these conversations with your family now, while you can still express those and have control over, letting people know what your wishes would be when the time comes. But really a referral to a formal palliative care department is ideal for many of these patients. And so again, here on this screen, just laid out for you all of the comprehensive support and care that's needed for these patients, and really comes down to a partnership between the patients, caregivers, and their healthcare team, of which pulmonary and cardiovascular rehab specialists are really an important part of. You may be the one to recognize this and help advocate for the patient. So just a few more slides in summary before I wrap up. As I've said, many of the ILDs share similar symptoms, physiology, radiologic findings. Can be a challenging diagnosis to make in this really diverse group, that they do share some things. They share the shortness of breath, coughing, and fatigue, and really just recognizing those symptoms early and getting the patient to the appropriate place for their diagnosis, an ILD center if possible. And in summary of a disease progression, we know that there's certain signs of the disease worsening. It could be one of these things. It could be all of these things that point to the disease getting worse or progressing. The multidisciplinary discussion is recommended for ILD diagnosis and patient communication, of which I do believe that pulmonary rehab specialists should be involved in if possible. And that this discussion that takes place between the multidisciplinary team can really be advantageous to patients in providing them a timely, accurate diagnosis with up-to-date options for management. And in summary, the comprehensive care of these patients. So we know that it's a partnership between patients, their caregivers, the healthcare team. Educational and emotional support is needed for patients. They should be evaluated early for oxygen, pulmonary rehab, lung transplantation if appropriate. Important to monitor and be aware of comorbidities, and ideally treat everything, optimize the whole picture of the patient. And then patients should receive a formal palliative care referral early to begin the discussion of late stage disease options. And that's all the content I have for you today. If you are interested in learning more, if you take your smartphone camera and hold it up to the screen over one of the QR codes, it will bring you to one of these websites. The one that I think particularly is helpful and would be most for this group is likely the Insights in ILD. That's the center one here with the picture of the lungs. Really an awesome wealth of knowledge on that site for you to learn more and more in depth about all of the different interstitial lung diseases. So with that, I think we're done today. Thank you so much for your attention. Thank you for everything that you're doing for all of our patients, and appreciate you joining me today. Have a great day.